So hi guys, welcome back again. In this video I'll be talking about part 2 of CTG. So in previous videos I have taught you about the basics of each component of CTG and other mode of intrapartum fetal monitoring. So in this video this will be a short session, and in this video I'll tell you about the CTG interpretation. How will you interpret CTG, and based on that interpretation what actions will you take and what will be your management. Okay, so let's start. The recent guideline is NICE 2022 guideline on CTG interpretation and categorization and the management of patients as per different category of CTG. So before coming to this video, please go and watch part 1, okay, of CTG basics, the video of CTG basics. So as per NICE guideline, it categorizes CTG including these 4 features into white, amber and red. So it includes contraction, baseline fetal heart rate, variability and decelerations. I have talked in details about all these features in the previous video. So based on these features, you will categorize the CTG into white, amber and red, and this denotes increasing order of severity or concern about the fetus. So white is normal, red is pathological, that is abnormal, and amber is suspicious. Okay, and we have to use this interpretation alongside considering the presence of acceleration to classify the overall CTG. So now contraction. So I have told you 4 features. First one is contraction. So when will you say that contraction is falling in the white category? If there are fewer than 5 contractions in 10 minutes. Okay. If there is 5 or more contraction in 10 minutes, which is known as hypertonic, then we put it in amber category. There is no such red category in contraction. So what will you do if it is of amber category, that is 5 or more than 5 contractions? You will do full risk assessment. You will inform patient what is happening and he will ensure adequate pain relief. So there will be more contraction, there will be more pain. You will also ensure, suppose if oxytocin is ongoing, is the dose more or what? So you will reduce the dose or stop the oxytocin as per need. So you have to perform the full risk assessment. You will assess the vitals of the patient, per abdomen, fetal heart rate, per vaginum, everything, and then you will take the decisions accordingly. Okay, then you have to provide adequate pain relief. Now the baseline fetal heart rate. So you know how to take baseline fetal heart rate. So in a 10-minute CTG strip, you have to take at least 2 minutes of strip where there is no acceleration or deceleration, and you will look for in which line it is falling, like in which line of the fetal heart rate it is falling. So that is the baseline, and you call it white when the baseline is stable, that is it falls between 110 to 160 beats per minute. You call it amber if there is increase in the baseline of more than or equal to 20 beats per minute from the start of labor or since last hour. Okay, or if the baseline falls between 100 to 109, or if the baseline is unstable, like the CTG is like this, you are unable to determine the baseline only, then you call it amber feature. Now when will you call it red feature? If the baseline is less than 100 beats per minute or more than 160 beats per minute. So lower baseline you usually see in postpartum pregnancies and higher baseline in preterm pregnancies. A rise in baseline may represent either developing infection or fetal hypoxia. Although the baseline between 100 to 109 is an amber feature, but we have to continue the usual care if it has been stable throughout labor, not during, like if it was 140 beats per minute earlier but now it is between 100 to 109, then will not continue the usual care. You have to again perform the full risk assessment and see what is wrong. Okay. But if the baseline has always been like this and there is normal variability and no variable or late deceleration, then it's an amber feature. It is suspicious but will continue with usual care. Now variability. If the variability is between 5 to 25 beats per minute, this is white feature. If it is less than 5 beats per minute, between 30 to 50 minutes, then it is amber, or more than 25 beats per minute for less than equal to 10 minutes, then it is amber feature. Otherwise, if it is less than 5 beats per minute for more than 50 minutes, or more than 25 beats per minute for more than 10 minutes, it is red feature. And if the pattern is sinusoidal, I also taught you what is sinusoidal pattern. So if there is any of these three, then we call it a red feature. Deceleration, this is very confusing, I can understand, but try to remember it, and it's not so hard when if you know the basic term, and that is why I taught you in earlier videos about these basic terms. Okay, so white features are if there is variable deceleration but without any concerning characteristics. So I have told you what are concerning characteristics. So if there is no concerning characteristic, then the variable deceleration will fall into white category. Or if there is no decels at all, or if there is early deceleration, all these three belongs to white features. And what is amber features? If there is variable deceleration with concerning characteristics for more than 30 minutes. Okay. Sorry, it will be less than 30 minutes. If it is less than 30 minutes, or if it is more than 30 minutes, or if there is repetitive late deceleration. What is repetitive? So suppose in a 30-minute strip there are contraction, patient is in labor, and if it is repetitive, that is present for more than 50% of the contractions, then we call it repetitive. And if it is less than 30 minutes, okay, and its opposite, if it is more than 30 minutes, it will be a red feature. Here also we saw that variable decelerations with concerning characteristics for more than 30 minutes is amber, but repetitive variable deceleration again for more than 50% time of contractions for more than 30 minutes, then we call it repetitive, and it will then fall into red category. So these three will fall into amber. Always remember, if there is any repetitive variable decel, see if it is for more than 30 or less than 30. If less than 30, then amber feature. If more than 30, for then it is red feature. And for late decels, if it is repetitive and even if less than 30 minutes, it will fall into red feature. And another red feature is acute fetal bradycardia or single prolonged deceleration for more than 3 minutes. Okay. So somehow I am trying to make it easy for you, by making this presentation, so it becomes easy for you to write even along with understanding, or to present in viva and all. So just try to understand, and if you are not able to, you can always ask me in the comment section. Okay, and those who know me personally, you can always ask me anywhere you find me. Now acceleration. I told you acceleration per se is not a feature to categorize CTG, but to give your overall impression on CTG, you can take into consideration the presence or absence of acceleration. Okay, so the four features I have told you: contraction, what is white and what is amber feature; variability, again white, amber, red features; then baseline fetal heart rate, white, amber and red features; and decelerations, white, amber and red features. Now additional factor is acceleration. So the presence of acceleration even with reduced variability is a sign that baby is healthy. So when you see reduced variability, and suppose you did fetal scalp stimulation and you see there is acceleration, so that is a sign that fetus is quite healthy. In the absence of acceleration on otherwise normal CTG, that is all the four features are falling in white category, and even though there is no acceleration, we do not that does not usually indicate that fetus is in acidosis. So see, okay, so that indicates that the fetus is likely to be normal if all other features, all those four features are falling in white category. So here is 10 into 10 and 10 and 15 into 15 rule. So if the period of gestation is more than equal to 32 weeks, you take acceleration and deceleration of 15 beats per minute and for 15 seconds. But if it is less than 32 weeks, then you take 10 by 10 rule, that is 10 beats per minute for 10 seconds. Again, this is the the chart here. Normal, suspicious and pathological category has been given, which I will tell you now. So what is normal? If there are no amber or red features, that is all the 4 features are white. What 4 features? Contraction, baseline fetal heart rate, variability and deceleration. If all these 4 features fall into white category, we call the CTG as normal CTG. But if any one feature is amber, we call CTG as suspicious, and if any one feature is red or any 2 or more feature is amber, we call the CTG as pathological. Okay. So what will you do if CTG is normal? You will continue the CTG and usual care. You will continue to perform full risk assessment at least hourly, and you have to document your finding as in labor care guide. Okay. And what if the CTG is suspicious? What will you do? You will first see if there are any concerning factors. Okay, if there are no concerning factors, then you will perform again full risk assessment. You will note if acceleration are present or not. If acceleration is absent, then fetus might be having some kind of acidosis, and if it is present, then it is unlikely that fetus is in acidosis. Okay. If the CTG trace was previously normal, so you are performing hourly assessment and you saw just 1 hour ago CTG trace was normal and now it is coming out to be suspicious, there has to be some underlying cause and you have to find the underlying cause. Okay. And then you take the conservative measures. Suppose if there is hyperstimulation, then you reduce the oxytocin. If baseline fetal heart rate or fetal base or any variability is less, then you have to look for, like if there is any deceleration, so you have to look for any acute events like abruption or cord compression or cord prolapse. Okay, so you have to see all this. And if there are intrapartum risk factors, then you have again perform full risk assessment. You consider fetal scalp stimulation. If there is acceleration on this, then it is normal, then the fetus is likely to be healthy, and if not, then there is something wrong, and then you expedite the birth. You suppose a patient is full and CTG is coming out to be suspicious, then you can apply instruments. But if a patient has not gone into, like, cervix is 4-5 centimeter or 6 centimeter and it's not progressing and CTG is coming out to be suspicious and new intrapartum risk factors are developing, then you have to expedite the birth by cesarean section. Okay, if instrumental delivery is not possible when the cervix is not fully dilated. Now if CTG comes out to be pathological, that is one feature is red and 2 or more features are amber colored, then what will you do? You will seek an urgent review by senior obstetrician, by your senior. Okay, then you have to exclude the acute events like cord prolapse, abruption or uterine rupture that need immediate intervention. Then you will perform a full risk assessment, maternal observations, and take the whole clinical picture and document your findings, and then consider whatever the underlying cause is there and take conservative measures as per the cause. Now you have taken conservative measures. Suppose you did left lateral position, there was suppose any event was there and you took conservative measures for that event, then what will you do? Suppose there was tachycardia, you made the patient to lie in left lateral position, there was oxytocin going on, hypertonus was there, so you stop the oxytocin, and you then again saw that there was hypertonic uterus, so you stop the oxytocin also. So these are all conservative measures. By doing this, sometimes the abnormality settles down. Okay, so but even after applying those conservative measures, there is no change in CTG. This is still pathological. Then what will you do? You have to expedite the birth, and you have to have a very low threshold. You cannot wait for long if fetus is in distress, if the CTG is pathological, because most likely there is some some acidosis or hypoxia developing. That is why the CTG is coming out to be pathological. Now what will you do if there is acute fetal bradycardia? You again always consider underlying causes and take conservative measures. This is true for amber features and red features, that is suspicious CTG and pathological CTG, and make an plan for urgent birth, including a request to pediatrics or neonatal support, because if fetus comes out to be not crying or in distress or not responding, then a senior pediatrician should be present there to take care of the fetus, of the baby. Then expedite the birth if acute fetal cardia persists for 9 minutes or less, if there are significant antenatal or intrapartum risk factor developing like abruption, cord prolapse and all. If fetal heart rate recovers by any time up to 9 minutes, suppose there up to 3 minutes you saw that there is bradycardia, then you are preparing the patient suppose for cesarean, so it takes time to shift and all. So up to then you saw that 9 minutes has gone by and now the fetal heart rate is settling down, then you have to reassess your decision to expedite the birth, but always take into account always antenatal and intrapartum risk factor. Suppose there is cord prolapse, you have to expedite the birth even though the fetal heart rate has settled down. Okay, so take into factors all these risks and discuss with the patient. Always inform the patient what is happening and what you are going to do, how you are going to manage the condition. If a decision is made to expedite the birth, you ensure the time at which urgent review was sought and the time that decision was made has to be documented. Okay, so all these are medico legal. You cannot wait for half an hour in case of acute fetal bradycardia. All these are the conservative measures which you have to take, which I had been talking in the CTG categories. Maternal position. So if a mother is lying supine, you have to tell mother she cannot be lying like that. That may cause supine hypotension and all. So encourage the mother to mobilize or take an alternate position, left lateral position. And do not offer intravenous fluid if mother is not hypotensive. Okay. And normally what happens if there is fetal bradycardia or tachycardia, many of us offers IV fluid to patient, but that will not help if there is no need of IV fluid per se. So if mother has no hypotension or signs of sepsis, you need not give IV fluid. But if mother is hypotensive, then you have to give. Hypotension may develop secondary to an epidural top up also. Okay, so you have to be careful in such patients who are receiving epidural anesthesia. So if hypotension develops, you should be giving IV fluid. You have to tell her to lie down in left lateral position to avoid supine hypotension, and you have to call the anesthetist if hypotension develops. Now if there is excessive contraction, you have to reduce or stop oxytocin and offer a tocolytic drug, okay, like terbutaline. Do not offer amnio infusion for intrauterine fetal resuscitation. This is not done. Be aware that the absence of acceleration in response to fetal scalp stimulation is a worrying sign, as I told you earlier. Do not offer oxygen therapy as a part of conservative measure. If saturation is normal, mother is not complaining of respiratory distress and all, you need not be giving such thing. Okay. And about fetal blood sampling, there is no recommendation as such as of now, because obviously it is an invasive method. Now, how long should we be storing CTG of a patient? At least 25 years. And there is teamwork and communication. Okay, doctors, midwives, mostly in South, mostly in UK. Midwives play an important part in management of OBS patients. So that is why NICE guideline have taken the names of midwives in many places. So doctor, midwives and nurses should be aware of how fetal heart rate traces are interpreted. So all of us should be knowing to interpret CTG and which fetal heart rate pattern is associated with actual or immediate fetal distress, and within which frame the member should be informed. Okay, so like we always have to inform our seniors while taking decision for the patient. Okay, so there is teamwork and communication, and again after each event we have to debrief our team. The senior most person of the team should debrief the parents regarding the events surrounding the birth. If something is happening, CTG is pathological, you are going to do conservative measure or expediting the birth, you have to always inform your team and the patient and the patient's family member attendants. So this was this short session. Please like and subscribe, and in case of any doubt please ask in the comment section. Thank you.